Unit 3 is all about complications, and we're going to start first with maternal complications. So Unit 3A is talking about hypertension, endocrine and metabolic disorders, postpartum hemorrhage, and other important topics that we need to cover as well. So first, let's talk about maternal morbidity and mortality. Why do we care what is happening with our moms? Well, let's take a quick peek. Here in the United States, we've got a serious problem. Our numbers are trending up. These are the number of pregnancy-related deaths for our mothers over the past couple of years, okay? In the last 30 years, this is what's been happening. What are our biggest causes? We've got cardiovascular conditions, we have infection, we have hemorrhage, we have cardiac, and then we've got hypertensive disorders. Absolutely, we need to be concerned about this. And we're going to talk about how this is breaking down to a state level, from a national point, etc. So let's first talk about hypertension. So we're going to be talking about the differences between gestational hypertension, preeclampsia, and chronic hypertension. So gestational hypertension is a common medical complication of pregnancy. They are a major cause of prenatal morbidity and mortality worldwide, not just here in the United States, because we have issues related to uterine placental insufficiency and premature delivery. Of the maternal deaths worldwide, about 10 to 15% can be attributed to hypertensive disorders. When we're looking at gestational hypertension, we're looking at just elevated blood pressure isolated. There's no other systemic findings. We're looking for things that would give us a preeclampsia diagnosis versus a hypertensive diagnosis. So when we're looking at just hypertension, we're looking at a systolic blood pressure greater than 160 and or a diastolic blood pressure greater than 90. So with gestational hypertension, we're looking at here ongoing or chronic blood pressure issues. I shouldn't say chronic, but ongoing hypertension issues prior to 20 weeks of delivery, or they can be diagnosed after. It affects about 4 to 5% of all pregnant women. Ideally, we would begin with begin with screening for these hypertensive disorders before conception. Why do I care related to hypertension? I mean, other than perfusion, we also get concerned about what's called placental abruption or abruptio placentae, in which literally the placenta detaches from the uterus. That placenta is our fetus's lifeline. Without it, our fetus dies. Something called superimposed preeclampsia, and then there's increased perinatal concerns or fetal concerns, such as intrauterine growth restriction or preterm delivery. Postpartum, after we've delivered this baby, we still are concerned for pulmonary edema, renal failure, heart failure, and encephalopathy. If we have something called chronic hypertension, then these are women who have pre-existing hypertension long prior to delivery. However, with that being said, they might end up with preeclampsia or eclampsia as part of their pregnancy. These can be very difficult to diagnose. When we're talking about preeclampsia, it is a subset under maternal hypertension. However, preeclampsia is very pregnancy specific, and we're going to see two key defining characteristics: hypertension and proteinuria. If we see hypertension without proteinuria, then we are concerned about gestational hypertension. However, the proteinuria tells us that now the poor effects of this elevated blood pressure is having systemic issues or creating systemic issues. Normally, this woman doesn't have any blood pressure issues. You're able to go back and look at her chart and look at her last several clinic visits, and we didn't have an issue at all. In the absence of proteinuria, if we don't have proteinuria, it's a diagnosis that we have to differentiate other things. So we have to look for lab results, looking for thrombocytopenia. We're going to draw her AST, ALT, bilirubin, looking at those liver functions. We're going to look at her renal function. How is her, how is her BUN? How is that looking? Are we concerned at all about pulmonary edema? Is she complaining about any shortness of breath? Or cerebral or visual disturbances? Is she complaining about headaches or spots? So how does preeclampsia happen? I can tell you what happens, but I cannot tell you why it happens. I cannot tell you exactly how we can screen for it earlier in gestation, because there simply isn't the technology to be able to do that. However, what I can tell you is that there are some risk factors, and I'm going to escape my screen here really quick, and I would love to be able to show you. This is the preeclampsia registry, and what I loved most about this is the infographics, and this is on your to-do list for this week to explore if you so choose. So preeclampsia, we're going to talk about eclampsia and HELLP syndrome momentarily as well. But let's talk about our African American, our Black population. In Rockford, we have a significant number of people that fall into this category, and so we have a significant number of people who are at risk, 3 times more likely to die from preeclampsia. Is that acceptable? Absolutely not. Absolutely not. Preeclampsia is also associated with 40% of our preterm deliveries. It is 60% of all maternal deaths associated with preeclampsia are preventable. So when you're talking about risk factors, we would be concerned about individuals who have poor to no prenatal care, and then as well our African American, our Black patients. Pathophysiology. So when we're trying to understand what is happening with preeclampsia, what we're looking at are what are called the spiral arteries. So when the placenta, those chorionic villi, those finger-like projections, first attach to the walls of the uterus, they have these spiral arteries that embed themselves into the wall of the uterus. Normally those are thick, and they are beautiful, and they are gorgeous. However, in preeclampsia, this vascular remodeling does not occur, or it only partially occurs. So as a result, if we don't have adequate blood flow to our placenta, once again, is our fetus going to do well? Is our placenta going to do well? No, they're not. Remember, the placenta is a huge organ, and it's requiring a lot of oxygen and nutrients. And if it's not able to get it, how is it going to show that? What's the manifestation of it going to be? So here you can see that we have that inadequate vascular remodeling. I've got another picture coming up as well. So we have this endothelial cell dysfunction. As a result of that endothelial dysfunction, we're going to have vasospasms, increased peripheral resistance. What is our increased peripheral resistance going to manifest itself as? Elevated blood pressures. And increased endothelial cell permeability. How are we going to see that? We start spilling protein from our kidneys. Our kidneys should be holding on to every last bit of protein that they can get, especially during pregnancy. There is no reason that we should be spilling that. However, if our cells become more permeable in their kidneys, at that endothelial cell level, they're going to allow things to pass through. Vasospasms, we'll see that as well. We see that increased peripheral resistance, as I mentioned, but then as well, if I go on to here to the next slide, these vasospasms release these pro-inflammatory proteins as this occurs, and this causes damage in our liver. Okay, so I really like this graphic. This spells things out for me a lot. To each their own. There's a couple different ways to look at it. But basically what's happening here is we see this placenta on the left-hand side. It's starving for oxygen. And then if you follow it across the top, we see that that diseased placenta releasing those proteins into the maternal circulation. We see this systemic vasoconstriction. You see it reflected in your patient's symptoms of hypertension and renal damage. And then perhaps as well you're going to see some changes to that liver function test. In the under the placenta in the lower left hand side, you see how baby is screaming, "I want a belly button." The curative treatment is delivery. So if our placenta and those defective spiral arteries are what's causing all of this to happen, then what do we need to get rid of? We need to get rid of the placenta. Can we get rid of the placenta and keep the fetus in? Currently, we don't have modes for placental treatments, or transplants, excuse me. So getting that whole fetus and placenta out are going to cure what we have. Again, here's another way for looking at it. This uteroplacental spasm, as you can see, results potentially in that intrauterine growth restriction. We're going to end up with a very small baby because baby is not being perfused, because we have spasms through the placenta, impairing all of that delivery of oxygen and nutrients. Cortical brain spasm, so that's reflected as headaches and hyperreflexia. We haven't even talked about that yet. That is also huge, and potentially, if it goes untreated, seizure activity. Right upper gastric pain, that's also going to be a big indicator, or epigastric pain if mothers complain about that in the presence of an elevated blood pressure. And then we also have hemolysis of red blood cells that can occur when we're talking about coagulation issues, all related to preeclampsia, especially if it's left untreated. So are we absolutely worried? We are really concerned. So some of the things we're going to look for, as I've already mentioned, include that elevated blood pressure and proteinuria. Now, edema is no longer considered a diagnostic criteria for the provider to diagnose preeclampsia, but it is something that you, as a prenatal or as an antenatal nurse, needs to be aware of. If you see this along with some other things, you're going to start recommending that your patient be seen by their provider, or you're going to flag your provider down. As you can tell, this edema is very positive. That's a plus for edema. How would you explain edema occurring? Again, let's talk about that endothelial damage. Instead of being able to release, and normally function the way that it should, instead our bodies are holding on to these waste products, and we're seeing that extra water retention reflected in the edema. Some of those other symptoms include that headache, visual disturbances, and that epigastric pain. For you guys, preeclampsia being such a high morbidity and mortality issue, when we're talking about NCLEX questions, this is where we're going to spend some time focusing on. NCLEX is definitely going to be wanting our triage nurses, our ED nurses, our community health nurses, our WIC nurses, everything that we do, they want us to have an idea of what to be telling these pregnant ladies. This morbidity and mortality rates are way too high in the United States, as we've already talked about. So they're going to be hitting this hard. I already mentioned that you're going to see some hyperreflexes as well. So we're going to assess for edema. We're going to get an accurate blood pressure. We're going to check those deep tendon reflexes. We're going to check for clonus, and we're going to do a urine dip for proteinuria. So let's talk about clonus. Now, this next video does not have any sound with it, but what I want you to see is what's happening during this assessment piece. Now, the provider in this case is lifting up the foot. Let's see here. Let me do this. Next, the practitioner will lower that foot onto the bed, and we no longer see that clonus. So as your assessment piece, what do you think that you should be doing? Should you be lifting up those legs? Absolutely. Absolutely. So let's talk about what we're going to do for these ladies with preeclampsia. So once we determine that they do have preeclampsia, and again, what are our criteria? It's not just elevated blood pressure, but we're also seeing those systemic effects. Those systemic effects reflected in things like proteinuria. What about edema? We might see it, but is it a diagnostic criteria? No. Remember? So keep that in the back of your noggin, that you would be concerned about it, but we need some other information. We need to get a urine dip, we need to check those reflexes, etc. Alright, so let's look at a blood pressure less than 150 over 100. Her proteinuria is holding stable. This mom has a normal platelet count and normal liver enzymes. So this would be mild gestational hypertension, or if we have that proteinuria, preeclampsia. Okay, so we're going to go ahead and we're going to orally medicate these patients, but we're not going to admit them to the hospital. So we're going to send them home, but they are going to have careful monitoring. So we're going to do frequent labs. We're going to provide all the patient education that we have to talk about how to look for changes in symptoms, when to notify us. When we bring them into the office, we're going to evaluate them again for these symptoms. We're going to monitor their blood pressure. We're going to encourage them to monitor their blood pressure at home as well. And then we're going to make sure that their fetus is staying healthy. Because remember, again, we're concerned about uroplacental insufficiency. We're worried about poor perfusion. How are we going to determine that? Very non-invasive, very inexpensive fetal kit counts. And then a non-stress test or a biophysical profile. We're going to encourage that they rest frequently. They are not on a strict bed rest. They are going to have a regular balanced diet, and we're going to encourage them to drink water like they should. Now, severe gestational hypertension, so that would be those blood pressures greater than that 150 or over 100. And now we have preeclampsia with severe features. So now our preeclampsia not is only spilling urine, but we've got some other concerning symptoms as well. We're going to put them on bed rest with the side rails up. Why do I care about side rails? We're concerned about seizure activity. We're concerned about our symptoms continuing to progress to the point, our neurological symptoms, that we end up with full-blown eclampsia. darkened environment, magnesium sulfate, we're going to be talking about mag here in just a second, and antihypertensive medications. We're going to be doing frequent maternal and fetal assessments. So putting on those bands, checking that fetal heart rate, using that tachometer to get an idea of how we're doing. So magnesium. How does magnesium work? I cannot tell you again. And I've heard my providers tell their med students the exact same thing. I can't explain to you why it works. I can only tell you that it does work. Okay? So magnesium, we use it to prevent and treat seizure activity. It is given IV. Now mag, you've got a loading dose of 4 to 6 grams and a maintenance rate of 2 to 3 grams per hour. It is not unusual for patients to come back from labor with mag running. It is also not unusual for patients to be held on the labor and delivery unit to have mag running in the antepartum period. So these are definitely indications for hospitalization. So what is a therapeutic mag level? It's between 4 and 7 milliequivalents. What are some possible side effects? So mag toxicity, if we're greater than 7, we're going to anticipate seeing some absent deep tendon reflexes, respiratory depression, blurred vision, slurred speech, severe muscle weakness, and it could lead to cardiac arrest. So we do have to keep a close eye on these patients. When you're talking about patient acuity, when you're talking about assigning patients by experienced nurse, patient load, all of those charge nurse responsibilities, you're going to be understanding that your patients who are on a magnesium infusion are not your typical prenatal or your postpartum patients. The anecdote, and this is a big one, is going to be IV gluconate or IV calcium chloride. So one of my most interesting stories from this first year of teaching includes when we observed medical residents who had a patient that was on MAG, but because they had this patient on magnesium sulfate, and at the same time they were watching her chemical, her CMP, her BMP, watching those liver functions and other electrolytes, they noticed that her calcium was low. Well, why is her calcium low? So they began to start supplementing her calcium while she was on MAG. It's like, you're just drowning out this is not the time to replace the calcium, okay? And calcium is going to be lower in pregnant women or postpartum because they just gave everything to that baby that they had. I mean, they take it from everywhere. So what are some of those medications, those oral medications that we talked about? Hydralazine, which is a vasodilator. You're going to see labetalol and nifedipine probably the most. So labetalol is that alpha and beta blocker. What is that going to do to our fetal heart rate if mom is still carrying, is still pregnant? It's going to drop that fetal heart rate. It does cross over the placenta. Nifedipine is that calcium channel blocker. So interventions, postpartum, we do need to talk about that. Okay, so because going back to that preeclampsia website, I mean, I can talk to you until I'm blue in the face about that we need to be monitoring these patients postpartum. But until you have had, until you've seen a patient whose blood pressure suddenly spiked, and I don't think that we screen well enough for our patients who are younger. I don't think that we keep a close enough eye on them. If you're 21 years old and your blood pressure is 130 over 80 in the hospital, we'll send you home without perhaps realizing that your baseline is 90 over 60. And that's what happened to my friend after her first baby. She was postpartum 3 days, and came home, or her husband tried to get a hold of her to come home on his lunch to check on her, couldn't get an answer and found her passed out. Very, very young. So there is a significant number of women with preeclampsia or with severe gestational hypertension who pass away, who die in the postpartum period, because we are not recognizing that the effects of those hypertensive blood pressures and those disease processes continue to manifest themselves for a period of time after the delivery. So it is concerning that if they had preeclampsia during delivery, that we continue to monitor their vital signs, their deep tendon reflexes, and their level of consciousness on the mother-baby unit. These ladies are unable to tolerate excessive blood loss. Well, why? We talked about that they can have platelet issues. We don't have platelets, we don't have the ability to clot. They have a 7-fold higher risk of developing preeclampsia with future pregnancies, and they have increased risk of adverse perinatal outcomes, which I already mentioned. One of those complications is called eclampsia. So if nobody notices that this patient's blood pressure continues to elevate with these severe features, or we are unable to stop the progression of this disorder, we can lead to eclampsia, or toxemia is the old word for it. It's the onset of seizure activity or coma in a woman with preeclampsia. They don't need to have anything pre-existing to red flag a provider or a nurse to this potentially for happening. And they happen, it can develop 50% during pregnancy and 50% postpartum. So what is going to tell you that your patient is at risk for developing a seizure disorder? If they start complaining along with your elevated blood pressure of a persistent headache, blurred vision, or complaints of epigastric or right upper quadrant pain, you need to intervene immediately. We don't want them to get to the point where they have an altered mental status. We do not want them to be convulsing. This is where we have our charge nurse on the phone with the provider, the primary nurse staying at the bedside, the PCT, making sure that we have suction equipment and we have padded side rails at the ready. We want to make sure that we maintain a patent airway and make sure that our client is safe. If this were to happen during the prenatal time period where we have not delivered this baby yet, in addition to making sure that mom is safe, we need to get after a seizure, we need to make sure that we get a good eye on that fetal heart rate as well, because during a seizure, there's the potential that we have compromised the fetal oxygenation, the uteroplacental perfusion. So let's get a good look at that fetal heart rate and make sure that it's where it needs to be. Again, another complication is called HELP syndrome. And HELP syndrome, I wish I could spend some more time on it, but your book doesn't, and I feel like that's personally doing a disservice. But HELP syndrome is one of those severe complications, and unfortunately we have seen women within the past couple of years even pass away due to HELP syndrome. It's a variant of severe preeclampsia. In addition to just seeing changes in the liver function, now we've actually damaged the liver. So we end up with hemolysis of our red blood cells. We end up with liver enzymes that are elevated as a result of the destruction, and we see low platelets. HELP syndrome can lead to DIC. DIC then causes a woman to essentially bleed out. So this is a result of arterial vasospasms, once again that endothelial cell dysfunction, and we have fibrin deposits, adherence of platelets in the blood vessels. These women can complain of just some malaise or influenza-like symptoms, but the telltale sign is going to be that they might report it to you right upper quadrant abdominal pain, or epigastric pain. These symptoms, this is another key indicator, they worsen at night and they get better during the day. So you go to bed, you feel terrible, you think, ugh, I shouldn't have eaten that pizza. And you wake up in the morning, you're like, I feel better. And you move about your day, never realizing instead that your liver is currently being destroyed. There's no reliable test or screening tool. I wish that we did have one to help us assess for preeclampsia. A low-dose aspirin might help certain high-risk women, but that has to be monitored so carefully and so cautiously. During our assessment, we're going to assist the provider by making sure that we have that accurate measurement of the blood pressure. We're going to check again for clonus and check for that proteinuria. We're going to ask our patients about those symptoms that we've gone over. And next we'll talk about bleeding during pregnancy.